So 2020 has been the year of the coronavirus, but will 2021 be the year of the vaccine? The planning of the pandemic and beyond. It's a mammoth crisis and a mammoth task as well. And what exactly is the government's action plan? We are now about to interview a person who is the troubleshooter, who is the one who plans along with other representatives and functionaries of the government, Professor K Vijayaraghavan, the Principal Scientific Advisor. Thank you so much, Professor, for joining us right here on NDTV. Now, the most important question, Professor Vijayaraghavan, is when is the vaccine coming? Now, I'm sure you've been asked this question a number of times, and I also know the fact, Professor Vijayaraghavan, that that's a wrong question. You can't put a date on something which will be, of course, there's an agency which is going to provide this answer. So my question to you will be different. My question is, what steps are left for India to roll out the vaccine, and by when will those steps be completed?
Thank you very much. Those steps which need to be done deal principally with three structures. One is the Central Drug Safety Organization, the CDSO, headed by the Drug Controller General of India. They evaluate safety data and immunogenicity and efficacy data of the vaccine from India and abroad. Those assessments are in progress and will be completed very soon, by this year end, i.e. a few days from now, or early next year, that's early January. After the drug controller approves a vaccine, in parallel with that actually, the National Technical Advisory Group on Immunization will approve it for immunization in the national immunization programs, as will the Health Ministry enter into discussions on how to roll it out. So all three are happening in parallel. Once the drug controller gives the nod, things will go very fast. As the Prime Minister has said several times, these are matters which the decision about when to roll out a vaccine should be left to our regulatory agencies.
Correct.
And their scientists to take a hard decision, and they will take it correctly very soon.
Correct. Now, Professor Vijayaraghavan, I know for a fact that you, along with others, have been planning the rollout of the vaccine for a very long time, even before these vaccines had completed their phase 2 or phase 1 or phase 3 trials. The government wanted that apparatus to be ready, right? In that context, I want to ask you, how are these dry runs going on as of this moment, which started, I think, yesterday?
Yeah. So the organizational structure which deals with the rolling out of the vaccine, the procurement and the rolling out, is a structure called NEGVAC, a National Expert Group on Vaccination. That's chaired by Dr. Vinod Paul and Mr. Rajesh Bhushan, the Health Secretary. They have put in place quite some time back detailed plans, which they over the last few months have actually structured it in a manner where that detail has mapped down to every single state and every single step. At the heart of this is a structure called Cowin, which is a IT backbone which deals with the procurement, the stockpiling, the distribution of the vaccine, and also the vaccination itself and its feedback that we know whether people have been vaccinated, where have they been vaccinated, when have they been vaccinated, whether it's the first dose or second dose. So all this is in place. Now, when such a huge structure, which is similar and comparable only to our general election structure, when that's in place in a manner similar to the general elections, we also need to make sure that everything is working. That's why you need a dry run, and there's a checklist provided by the Health Ministry, and beneficiaries will be given dummy vaccines at different locations in each of 4 states, in districts in each of 4 states. That's Andhra Pradesh, Assam, Gujarat, and Punjab. And these people then will be, routes by which we check whether the vaccinator, the office system, the feedback system, everything is in place. This is vital because the moment the vaccine is approved, then we can roll out and be sure that the entire system is working.
Now, Professor Vijayaraghavan, it's very interesting that you mention technology and data and its use in the form of an app called Cowin. I want to ask you, is this the first time something like this is being attempted for inoculating people, technology and its use of this kind? And while you were envisioning this, What were the envisioned advantages of using technology to its fullest potential? And as you are also aware, technology has a negative side also. So have you factored in those challenges? Leakage of information.
Yeah. So Cowin is an entire IT backbone, not just any particular app. Now, for our large-scale childhood immunization programs and maternal immunization programs, for many years now, the health ministry has got a vaccine intelligence network in place. That's also an IT network. Now, what that does, and this is why an IT backend is necessary, is it makes sure that vaccines are kept at the right temperature, that they're diluted from manufacturing hubs to stockpiling to distribution. Everything is done properly. Every step has to be right. You cannot have a misstep and you're going to give billions of doses. So this is not a question of having technology or not, but linking technology with people and constant feedback so that you make sure the decisions are taken. So it's not something which is left to technology. There's a huge network of people which have been put in place without compromising our regular immunization program. All that is being tested out in a representative way in our dry run. So a combination of people and technology is what is there.
Now, Professor Vijayaraghavan, those who are going to be vaccinated are also supposed to be in use of this technology. For instance, they will have to furnish data and only provided they furnish that data on an app, they will be entitled to get this vaccine eventually as part of phase 1 is what I have read. A very common concern here is going to be how will you reach out to people who do not have access to technology or do not have internet connection, do not have a phone?
No. The technology is not required for people to be vaccinated at all. All people need is a way by which they can be identified as having got the vaccine the first time, and therefore they get the second dose at the right time. There are multiple routes to identification, and those who have access to technology could use that. Those who have access to Aadhaar can use that. There are other ways of identification. It's agnostic to what method people identify. Nothing to worry on that.
And how will that be done? For instance, in the back of beyond of this country, as an individual who needs that vaccine but does not have access to technology. I'm sure you must have thought of this, Professor
country.
Yeah.
No. Not only, I've not thought of it, but it's not me who does this thinking. It's the health ministry and the enormous network which have done this for decades. They have, we have removed smallpox from the country, polio, maternal tetanus, and we have vaccinated children every year. This is an enormous network which keeps going again and again and keeps improving year by year. So on that layer of understanding and experience, they're doing something which is actually has similarities, but it's on a much larger scale of course. Never before in the world has any country of this size has the requirement to vaccinate so many people so rapidly. So, but we have a reassurance that we can reach anywhere, in the smallest locations, in the most difficult places. And that's been done for multiple vaccinations, and that'll be done here too.
Sure. Now, Professor Vijayaraghavan, a question on these vaccine candidates that are under consideration. Assuming many get approved, right, because there are many such candidates, how is the government planning to decide who gets which vaccine?
Well, the first vaccines which will likely to come out will be rolled out in January. They are going to be also vaccines which are going to be available in very large doses. And this will be the situation in the first quarter. Other vaccines will also come up and their dose requirements will, dose availabilities will ramp up. So the first quarter, we're not going to see an issue of multiple vaccines really. By the time the second quarter and the third come in, we're going to have multiple vaccines licensed and go, and the vaccination program will go ahead. One route is that people who have, of course, got the first dose, they're likely to get the second dose of the same vaccine. And vaccination programs can be tailored so that they're distributed, different vaccines are distributed across different states or regions or priority groups. Those are the kinds of logistical arrangements which will have to be made.
No, this is interesting, Professor Vijayaraghavan, because you mentioned about logistical arrangements. I'm sure you're aware the world over this is also a concern where different vaccines have different cold chain requirements. So do we have all of that in place?
The vaccines typically, like for example, the AstraZeneca Oxford vaccine manufactured by Serum has a relatively modest cold chain requirement, which our vaccination program already has. But again, this has to be scaled enormously, and that will be scaled. Other vaccines have a lower temperature requirement, such as a -20 or a -70. And while many people have legitimately expressed concerns on that, I don't think that is an unsurmountable problem. And indeed, it's a solvable problem because we have an extraordinary infrastructure of cold chains for multiple other reasons also, ranging from our medical sector, from our research sector, and so on. And many private companies are stepping in that range. So as those vaccines which require a greater cold chain step in, I don't see that as a pretty big issue.
Okay.
What will happen in some of the most stringent ones is that those vaccines will go to specific centers and people will go there. Unlike the other vaccines which have a lower stringency of temperature requirements, where the vaccines will go to people. So this kind of a balancing is one way to deal with those.
Interesting. It's interesting. So that's how the slotting will be done of the vaccines. That the more demanding ones in terms of logistical planning will be available in a counter, and those that can go to the people will go to the people. Is that how it's been planned?
Well, that's one way of dealing with it, simply because even district hospitals, smaller hospitals can have very robust freezer setups available, and people can go there. And the other vaccines can go directly to people. But there's also ways by which carry-on packs, which have been developed globally and have been used in India for other purposes, where refrigeration can be dealt. Let's cross that bridge when we come to that about refrigeration requirements. But I don't see that as a big problem.
Sure. Professor Vijayaraghavan, one last question on the vaccines, and then I'm going to come to the new strain. You held a press conference about it also just a short while ago. Now, vaccine candidates like the Serum Institute, they say that they have doses in the millions that have been made and are ready, right? So the moment they get approval, they will be available. But what's our plan on getting the right amount of doses that we need? Because see, this institute or this company also has its commitments to COVAX countries to give a part of their vaccines to other countries as well.
It's important to keep in mind, again, our national commitment reiterated by the Prime Minister that India is a responsible vaccine manufacturer. It has both a Gavi, which is a major vaccine alliance. It's a Gavi recipient country, which means it gets vaccines at very much lowered costs from abroad. But it's also a Gavi donor country, which means that it funds Gavi to support vaccination programs in countries which cannot afford it. So in this responsible role, India will do both. It will serve its own citizens and ensure that its manufacturing capability, which is one of the largest in the world, also serves the rest of the world. This is not a either-or situation. And we must keep in mind, as many people have said, that no one is safe till everyone is safe.
Yeah.
There's no point in having vaccinations in a secluded area. Vaccination has to be global in this pandemic.
Now, Professor Vijayaraghavan, one word on the efficacy as far as this Oxford vaccine is concerned. There are claims that there is 95% efficacy, but even that has not been verified. Do you think this is what is keeping our regulators and studying more data before giving an approval?
Well, first of all, I would not second guess our regulators. Let them do their job. Now, the question about efficacy is an interesting one. Efficacy of a vaccine is measured when in trials it is compared with those who don't get the vaccine to see how much disease progression takes place. So when both control and vaccinated groups get exposed to the disease, do the vaccinated groups show much fewer severe disease symptoms or even mild symptoms? So that's sort of a very carefully constructed structure, because you take care of watching both placebo and vaccinated people very carefully. Now, in that situation, when efficacy is high, anywhere between 60 to 90, as we've seen in various vaccines, it's very likely that on the field, where you are going to now vaccinate hundreds of millions, the effectiveness of a vaccine, which is how much it protects in the field, is likely to be substantial and absolutely sufficient.
Okay, that's interesting. Let's now, Professor Vijayaraghavan, talk about this new strain. You held a press conference also today. Now, new mutations are spreading enough fear. You know that more than I do. Are these vaccines that are being considered or under consideration, are they going to cover these different mutations as well?
So right now, what the mutations which have led to these new strains, what they do is they cause, principally of interest to us, variations in something called the spike protein. The spike protein is a protein on the virus which attaches receptor on our cells and then enters the cells. So these new variants have got changes in the spike protein which allow them to bind better to the receptor, and also to entry into susceptible cells are easier, and that's why they cause greater transmission. But the spike protein is a very large zone, and the vaccines attack that entire region and not just the region where the changes have taken place. So from every estimate, there is no reason to worry that the vaccines will not be effective. Now, what's happening in the UK is that this strain has shot up in terms of frequency in the population, and also the numbers of cases have increased. So the UK has also already started its vaccination program. So the proof of this assertion that the new variants will not affect vaccination will be seen very, very soon in a setting like the UK.
Yeah. Now, Professor Vijayaraghavan, just a quick addition to that question. If vaccines are fine and they cover a large variety of mutations, then why is this, this big worry globally? Why are we worried about the mutation? Because the virus is known to mutate. It will keep mutating. And secondly, a very, very important question that came in from a viewer, that if a person has recovered from COVID-19, should he or she be worried of this new mutation? Or will the antibodies take care of this new mutation as well?
Okay, both are very important questions. Let me be very brief about the first point. If you look at the virus's genetic material, then random changes occur as it propagates throughout the world. Most of these changes are entirely meaningless to the virus or to us. They just are useful for tracing the path of the virus, because you see where the mutations are prevalent in space and time. But some mutations, as you have seen in the UK variant or in the South Africa variant, can cause increased transmissibility. Now, they will not, these are matters of general concern, because what happens in the UK can happen anywhere else in the world, or what has happened in South Africa can happen anywhere else in the world. There are very, very large areas across the world, the US, India, all of Europe, in Africa, where there is free range for the virus to mutate. If by some chance a mutation occurs in any of these regions, which increase transmissibility or severity of disease, or even, unfortunately, such a large number of mutations which prevent the vaccines from acting, we could be in a matter of serious concern. That's why we must sequence a very large number of samples, both from passengers coming in internationally and within our population, to make sure that we understand where changes are taking place. And that's a major effort which the government and its scientific agencies and scientists have embarked on.
And that process has already begun. I heard the government saying that in the press conference. Now, Professor Vijayaraghavan,
Just the second point,
sure.
Asked, if one has recovered from, one strain, are you protected against the, UK variant? Now, as I said, the antibodies against the which the body raises are in many ways similar to what the vaccine raises, except the vaccine does a much more controlled and usually much more efficient job. There's a lot of variation in people in terms of their response. Some people might have a mild response, some people might have a strong response. And remember that this UK variant, while it transmits more, it doesn't seem to cause a more severe disease. So it's moot about the sequence of the UK variant and other ones, whether you will get reinfected or not. It's very unlikely people get reinfected. There are some rare examples where they could have been reinfected, but in general, reinfection doesn't seem to be a big problem.
Okay. I think that will come as a huge relief. Your words are going to come as a huge relief for everyone, but of course, precaution has to be taken. Two quick questions before I wrap up this interview. One is on reimmunization. See, we know that viruses have a tendency to mutate. Something as common as influenza, like the common flu, it keeps mutating, and then you have to keep updating or upgrading the vaccine year after year. Do you see something similar happening for COVID-19 also, which means one jab is not going to be enough?
We don't know yet, but typically for many viruses, particularly respiratory viruses, year on year, it can happen that the following year's variant is vaccine recalcitrant compared to the previous year, or at least less so, as happens with influenza. In that situation, we are now actually very well prepared for continually looking at that and responding to that. As I said, in the early phase, vaccines are going to be in short supply. Later on, they're going to be available in wide levels. And after that, we enter a continuum phase where this kind of monitoring will take place. And, we can keep looking at the virus and keep tweaking vaccines if needed so that they can deal with any incoming change, which is recalcitrant to the previous year's vaccine. We don't know that yet about this.
Correct. A lot of things that are unknown about this virus. My final question, and I've saved this one for the last, Professor Vijayaraghavan, because I saw a tweet of yours, and this is a very interesting tweet based on a write-up that you have written. You say that we have to get science closer to the people, and this trend has to be irreversible. It has to continue. Can you put this, this comment of yours in context? Why do you feel so, more so now?
Well, there are three parts to this. One, people today want not only the fruits of research, but they want research also. And they want, secondly, research to be speedy and, benefit them. So these are two very good aspects. The third aspect is scientists have for long said that invest in science and the payoff will come in due course. But today, we have seen that this large investment over many, many decades has paid off enormously in terms of application of science to the good of people. Now, are there ways going ahead by which we can make this happen a lot more? Science does take a long time for returns to come in, so investment for the long term is necessary. Simultaneously, you need another component of science which deals with our issues on a day-to-day, week-to-week, or month or yearly basis. Is that also simultaneously possible? And I think this year has shown a very positive side of how that actually can happen. We need to invest in that and have that compact between science and people robustly put together forever.
Well, here's to more science and more research. Professor K Vijayaraghavan, thank you so much for joining us in this very, very candid conversation. Thank you so much, sir.
Thank you very much.